Good day, everybody, and welcome to this session. The title of this on-air session is The Role of Innovation and Cross-Sectional Partnerships in Advancing Breast Cancer Control Globally. 1 in every 8 cancers are diagnosed in 2020 is breast cancer. According to the Global Can projections, the existing cancer burden is expected to grow, with the number of deaths expected to multiply by 51% by the year 2040. Greater than half of the breast cancer cases are diagnosed at advanced stages in many low to middle income countries, where the cancer is more difficult to treat, expensive, and usually incurable. In 2020, the UICC intensified its engagement in breast cancer by launching a comprehensive strengthening and engaging the global breast cancer community with the goal of reducing the premature deaths and improving the quality of life of our cancer patients. Earlier this year, the WHO launched a global breast cancer initiative aimed to reduce global breast cancer mortality by 2.5% per year, thereby averting 2.5 million breast cancer deaths globally between the year 2020 and 2040. The main objective of this session is to emphasize the importance of increasing efforts to tackle breast cancer, showcasing the opportunity of innovative technologies and cross-sectoral partnerships to drive action and achieve improved breast cancer outcomes, highlighting the WHO Global Breast Cancer Initiative, its global strategy, and noting UICC's role in strengthening and engaging the breast cancer community. We have 3 speakers for this session, and we'll call on Professor Ben Anderson to talk about WHO Global Health Cancer Initiative, paving the way for reducing global breast cancer mortality. Professor Anderson is not new to any of us. He's a professor of surgery and global health medicine from the University of Washington and the Fred Hutchinson Cancer Research Center in Seattle, Washington. After serving as director and chair of the Breast Cancer Global Health Initiative for 20 years, Dr. Anderson has joined the WHO to lead the WHO's initial foray into global health breast cancer called the Global Breast Health Initiative. He also served on the UICC Board of Directors from 2012 to 2018. Over to you, Dr. Anderson, for your talk.
Well, thank you, Dr. Vanderpuye, for that kind introduction, and thank you to UICC for the opportunity to present on the Global Breast Cancer Initiative in this nice session. So I think it's important to begin with a good understanding of the breast cancer prevalence and incidence globally. Breast cancer is the most common cancer among women around the world. As of 2020, it's the most common cancer around the world. Most likely reason that a woman will die of cancer. There are more disability-adjusted life years lost to breast cancer than any other malignancy. The majority of breast cancer cases and deaths already occur in low and middle income countries, and this problem is becoming increasingly exaggerated. By 2040, 60% of the projected 3 million new breast cancer cases and 70% of the 1 million new deaths will be in low and middle income countries. The 5-year survival varies greatly around the world. It's greater than 90% in high-income countries in North America, Western Europe, and Australia, but it's 66% in India and 40% in South Africa. So this is clearly a statement of disparities. It is also a statement of opportunity because it shows that we know what to do with breast cancer. The question becomes, how do we translate this in meaningful ways to start to see greater equity around the world? In sub-Saharan Africa, half of the breast cancer deaths occur in women under the age of 50. And for every 100 of those deaths, there are 210 children that become maternal orphans. So this is not only a social problem, an economic problem, a family problem, this is a generational problem. And that's one of the reasons that we need to be addressing breast cancer beginning now. Clearly, prevention is an ideal strategy. If we could avoid developing breast cancers altogether, then that would be ideal. And that's a fundamental cancer strategy. We know that if there is more lactation, if we avoid if we have physical fitness, weight control, avoiding excess alcohol exposure, avoiding the use of hormone replacement therapy outside of clinical indications, avoiding radiation exposure, these would all reduce breast cancer incidence. And there are multiple NCDs, non-communicable diseases, that would be benefited in this way. So these are good strategies. However, if you ask what fraction of breast cancers would be addressed if we could affect all of these, this is maybe 20% of the cancers that are diagnosed. So we do need to go on to think about how to implement beyond the cancers once they exist. The objective of the Global Breast Cancer Initiative is to reduce breast cancer mortality by 2.5% per year. And if you do the math, that would avoid 2.5 million breast cancer deaths between the years 2020 and 2040. There are 3 pillars to this initiative. The first is health promotion for early detection. This is an educational initiative. The second pillar is timely breast diagnosis. And the third is comprehensive breast cancer management. But fundamentally, this is a marriage of 2 ways of thinking about cancer management. There's the public health sciences way of thinking, which is looking at populations as a group. And then there's clinical management. How do we manage patients one at a time? We have to address both of these. If you look at the population level, what you're seeing here on this graph is the breast cancer mortality rates between the 1950s and the present time. And what you can see in high-income countries has been there was an increase in breast cancer mortality associated with doing better with other diseases, higher awareness. But then in the 1990s, we started to see this plummeting breast cancer mortality. And that drop was between 2 and 4% per year. So if we talk about a 2.5% drop per year, that's not an artificial number. This is an achieved number. And so for that reason, that it's a meaningful target for us to think through. And this was done with tools that today we would consider standard. The question then becomes, how do we take that, what we've learned in that environment, and translate it into environments that have not yet seen that benefit? This is the universal patient pathway, and this is the biology of breast cancer. And so it's really no different whether one is in Accrw, Ghana, or in Seattle, Washington. There are 3 intervals. The first interval is the patient presenting to the system. The second interval is the diagnosis that's being made. And the third interval is the actual treatment or management that takes place. We tend to talk about screening, mammographic screening, as being the entry point because this has been a common discussion in high-income countries. However, there are many resources that need to be in place before one can begin screening. And actually, the majority of women globally are presenting with symptoms. You have to be able to manage the symptoms that you can see or feel before you do screening. Screening is where we're looking at women who are asymptomatic. We don't know if there's any disease until we get the imaging. And it's much more complicated to manage cancers that you cannot yet feel or see. And that's why clinical diagnosis becomes the first strategy. So in that first pillar, the educational pillar, we want to promote downstaging of disease. And ideally, what we need to do is get to at least 60% of the invasive cancers being stage 1 or 2 at diagnosis. The reason 60% is that indicator threshold is because that was the level at which all of those countries that had that dropping mortality, they had at least 60% of their invasive cancers being stage 1 or 2. This is an educational initiative. Health literacy, the public needs to understand what breast cancer is, how it presents, and why early detection and treatment is so essential. We want to link this to other activities. So if we're promoting cervical cancer screening for ages 30 to 49, this is also an opportunity to educate the public. But we also have to educate the providers. The primary care and secondary level providers need to recognize early breast cancers, not just assume they're infections and send them away with an antibiotic. And that means that educating the primary care providers and educating those at the district level where diagnosis is performed, knowing how to work up a breast lump in ways that are effective. This is really a key strategy. The second pillar links tightly to this, which is cancer diagnosis, that we want to make a diagnosis within 60 days. And if you ask, why is 2 months that period? It's because at 3 months, that's when we start to see gradually worsening breast cancer survival. So it's an appropriate target for that indicator. Rapid diagnosis has a lot to do with organization. So these are standard tools, ultrasound in Rwanda, pathology taking place in Ghana. We can set these things up. It's that we need to navigate the patients through these systems in ways that are effective. We want to use effective pathology services. These have been lacking. There's standard pathology such for diagnosing cancer and for knowing the tumor markers. So doing immunohistochemistry is complicated, even in high income settings. So using leapfrog technology based on PCR would be one method for addressing this. But we have to navigate the patient through the system. They need to be able to make their way through in ways that are timely and effective. Consider this example from Tanzania. What we learned in this situation analysis was that the patient first entered the system at the primary care level, but needle biopsy wasn't available until level 4. So the patient would need to be referred 3 times to an increasingly distant center before they would actually be able to have a diagnosis made. Well, not so many patients are going to make them, and they're going to have the most advanced stage disease. This is really a balance in the health system between centralization for optimizing quality versus decentralizing for optimizing access. And the answer to how we balance this is going to be individualized based upon the country and specific situation. In terms of cancer treatment, that third pillar, we need to ask the question, what do we do in the Regional Cancer Center in Peru or Tata Memorial in Mumbai? And we know a lot about this, that the idea is to get the patient through comprehensive cancer treatment all the way through to the end. Because if we just partially treat the patient, that's the worst of all worlds. That's giving them the side effects without the full clinical benefit. So we need to have timely access to multidisciplinary care. That means surgery, radiotherapy, and drug therapy, not to mention supportive care that gets them through this. We have to navigate the patient through this system. And we have to measure our outcomes. If we don't measure how we're doing, we won't know if we've improved or not. And then we can't forget about the patient when we're done. She has to reintegrate into the community with minimal financial toxicity. She needs access to follow-up care at the primary level, and she needs to have survivorship and supportive and palliative care available in that community as well. The Global Breast Cancer Initiative is comprehensive in thinking about how to manage these strategies. That support at the patient level is essential. So reintegration, managing stigma, financial health, supportive care, and palliative support, this is where our advocacy and NGO groups fit in making sure that we're properly representing the patient and thinking about it in that setting. Consider this example as a model for sub-Saharan Africa, where we are going to implement strategies in a country-by-country way, assessing, planning, implementing, and monitoring. This is fundamental to health system strengthening. We don't stop with one round, we keep going. So here in this applied example, we know that in sub-Saharan Africa, it's very common to have cancers misdiagnosed, leading to delays, disorganized navigation, leading to delays longer than 2 months. Immunohistochemistry is difficult, and the cancer centers become overloaded because of all these leading to these treatment delays. If we could identify an approach where women with a palpable mass could undergo diagnosis in a prompt fashion and being identified as being estrogen receptor positive rather than negative, taking those patients and starting them on endocrine therapy, tamoxifen or an aromatase inhibitor, we would be making the system work. And this is the exact same approach that we took in high-income countries when we implemented COVID-based strategies. Endocrine therapy allows us to delay the more complex management in these settings. Thank you very much for your attention today.
Thank you very much, Dr. Ben Anderson, for that enlightening talk. I have a couple of questions for you. The first one would be, how would you advise governments in weaker health systems to tackle patient factors in reducing diagnostic delays?
Well, you have to begin by assessing the situation and recognizing diagnosis is the part that is often overlooked. And so in these weakened settings, we need to build in logical frameworks. This is the concept of resource stratification. So there's certain fundamental elements that need to be in place. Having rapid diagnosis units would be one of those, but recognizing it has to connect to treatment and identifying the patient pathways through which this can be effective. This is a central role that the ministries can play in identifying how is my system working and do I have the most fundamental and sustainable approaches established?
Okay, thank you very much. The next question is, you talked about decentralization versus centralization. How would you advise governments to safely decentralize to improve access to breast cancer care?
So improving access is necessary because you can have all the perfect systems, but if the patient can't get to it or gets to in a very delayed fashion, you can predict that they will have worsened outcome. What you want to do is promote education and information transfer. So if the primary care provider is sending the patient to the local hospital, and then that local hospital sends the patient on, once cancer is proven, to that tertiary care, that information needs to be transferred back to the district and local levels. This is the only way that they can improve. If you never find out what happened to the patient with a lump, how would you know what to do better the next time? So thinking of information systems as an essential component and for navigation, I think is one of the strategies that can be adopted.
Thank you. How would you advise local advocacy and survivorship groups to empower them to centralize on how to improve breast cancer outcomes within their countries? What would be your advice?
I think that the advocacy groups are essential in two directions. So one direction is that they provide the feedback to the medical community and to the policymakers about what is it that we need. We do better as teams in promoting this, and so they represent the community well. To that end, they need to make sure that what they're advocating for is the right thing, that they're not advocating for something that might be relevant in a different area, but isn't what they need next. And similarly, they create awareness. It's the advocacy groups that talk to the community. Who listens to their doctor? Nobody listens to their doctor, but you may listen to your neighbor. And so that they play this central role for communication in both to the public and to the powers that be.
That is a very important step. Okay, thank you very much, Dr. Amberson. I would like to introduce Jane Brock. She's the Chief of Breast Pathology and Medical Director of Surgical Pathology at Gossing Room, Brigham and Women Hospital in the USA, and the head of the Breast Pathology Fellowship. She's a program director. She has unique academic interests in global health and innovative methods of cancer diagnosis used in low to middle income countries, including the quality metrics of these. She has also worked in Rwanda, China, and Myanmar. And her talk is going to be addressing breast cancer inequity through innovation, exploring the potential of new diagnostic technologies. Welcome, Jane.
Thank you for the invitation to speak. I'm going to talk about timely cancer diagnosis using standard and leapfrog technology. So for the treatment of breast cancer, we need to provide an accurate cancer diagnosis and obtain the prognostic factors that will guide the treatment decisions. And it's really not necessary to recreate all of the workflows that are present in high-income countries. Our traditional workflow for breast cancer diagnostics is starting with breast imaging and image-guided core needle biopsy of a tumor mass. Then that tumor is sampled and evaluated by pathology. The pathologists confirm that there's carcinoma present, and they will give it a grade, which is how rapidly it's growing. The pathology service also provides the prognostic markers, in this case, estrogen receptor, progesterone receptor, and HER2. There's also an assessment of the clinical stage of the patient, the tumor size, whether it's already spread to lymph nodes, and any evidence of distant metastases. And together, all of these factors will determine the surgical and the medical treatment options available for the patient. So how do we get from a patient presenting with a breast mass to a diagnosis? Well, we have to start with a tissue biopsy procedure. And the best of these is the core needle biopsy. This is the optimal specimen, but you can also perform fine needle aspiration or an incisional biopsy using a scalpel. Once you have that tissue sample, it's sent to the pathology labs for processing. And this is a really labor-intensive, time-consuming, and expensive process. The tissue is processed by using preserving and dehydrating chemicals, and then it's embedded in a paraffin block. Then you have slices cut from that paraffin block placed on a slide and stained with dyes. That's called hematoxylin and eosin. And then the pathologist can look under the microscope at that stained image and make the cancer diagnosis. And then the pathology services can evaluate biomarkers by performing immunohistochemistry on additional sections of the tissue cut from the block. So how do we use technology to get to a cancer diagnosis more easily when resources are limited? Well, I'm going to outline 3 different ways. First, telepathology to provide and improve the pathology diagnosis, a little bit about a computer-assisted diagnosis, and then molecular evaluation of prognostic markers, which can be used to reduce costs and solve a lot of the quality control issues. Starting with telepathology. This is when you make a really high resolution digital image from an H&E stained glass slide, and we call this whole slide imaging. There's a whole range of commercial technologies available at very variable cost, and that cost is depending upon the speed and the quality of the scan and how much data organization you purchase along with the technology. So the idea is that a pathologist, perhaps even on the other side of the world, can review these images via the internet and make a diagnosis. And as an example, the American Society of Clinical Pathology has an expanding cloud-based telepathology service in Africa and in Asia. And pathologists provide expert diagnostic support for the local pathologists, and it's also used as an educational tool. Telepathology can also be used to provide diagnosis for hospitals that don't have any pathologists in them as well. So looking at computer-assisted diagnosis, this is when you use an artificial intelligence algorithm to read the digital image, for example, to make the cancer diagnosis or to predict the biomarker ERPR and HER2 status. It can even be used to predict benefit from chemotherapy or endocrine therapy, sort of like a digital version of a molecular profiling. Now, we're near a future for making the cancer diagnosis and predicting the biomarkers, but there isn't anything currently commercially available. And from my own experience and from what's published in the literature, it's pretty easy to get 70% accuracy with these algorithms, but it's really hard to get 90 to 95% accuracy, which is where you really want to be for this. Looking at biomarker testing for ERPR and HER2. Our traditional pathway is using protein immunohistochemistry and HER2 FISH assays. And really the focus has been on centralizing testing for quality control and efficient use of resources. We know that there are multiple challenges for performing immunohistochemistry in FISH and LMICs. We have problems with the cost, with the reliable supply chain, with quality control of the assays, and the technical skills needed to both perform and interpret the assays. So an alternative biomarker assay is actually measuring the mRNA levels in the tumor. So we can assay ERPR, HER2, and Ki67, the breast biomarkers, and get excellent concordance with the protein immunohistochemistry, over 90–70% for ER and over 95% for HER2. And I'm going to illustrate this with an example of an mRNA assay that's being used in Rwanda. In the first phase, 150 samples of tissue that were fixed and processed in Rwanda were tested in the US. And this was a real challenge, the assay study that has been published now. There was good ER and HER2 concordance. And it's in phase 2 right now, trialing the assay use in the Butaro Cancer Center in Rwanda. There's also an ongoing cost-benefit analysis in place. And I want to walk you through that cost-benefit analysis for using this assay. So if we look at the reliability of the supply chain and availability, the assay kit and the cartridge contains all the reagents needed for the assay. The assay runs on a PCR amplification machine that's already in the key hospitals. Servicing is available, and there's some remote in troubleshooting available by the company. The assay cartridge, however, may be difficult to obtain. That will be the downside. Looking at the quality control, no external quality controls or human-reliant quality controls are required for the assay. The cartridge has a similar shelf life or expiry to immunohistochemistry reagents. The retest rate of a failed assay, which is in the first study that Rwanda performed, was 2.6%, is pretty comparable to immunohistochemistry. The assay does eradicate the false positives that we get with low ER immunohistochemistry results. And it does eradicate an equivocal category for HER2 results. And that can be between 7 and 25% of cases that get tested. So that really means you don't then need to do FISH. It eradicates the false positive HER2 immunohistochemistry results as well, which are also recognized as a quality problem. Unfortunately, it doesn't erase the challenge of poor tissue fixation and the delays with tissue fixation that can cause erroneous results, but these can cause erroneous results with immunohistochemistry as well. Looking at the technical skills required, you do need some lab technical skills. You need your basic histopathology skills, and you need some basic computer literacy to run software controlling the PCR machine. But the advantage of the assay is that you don't require it to be interpreted by skilled or experienced pathologists. When it comes to cost, the current cost of immunohistochemistry is estimated to be about $60 per case, and this is based on economic models for 7 sites across Africa. The cost of the mRNA assay cartridge is not fixed yet because it's not in mass production yet, but very similar technology for infectious disease cartridges in eligible low-income countries is around $10 to $20. The PCR machine itself varies in price from $5,000 to $17,000 depending on what type of machine you buy. And if you compare this with immunohistochemistry setup costs, which is up to $30,000 for manual immunohistochemistry and $50,000 for automated immunohistochemistry, there are some cost savings there as well. Some other considerations, you can get same-day biomarker results. There's a 2-hour turnaround time. When you do find out if a tumor is HER2 positive, that tells you it's a very aggressive tumor and that it will benefit from chemotherapy, which is useful information to have even when you don't have HER2 targeted therapy available. That HER2 positive result also tells you what the prevalence of HER2 positive tumors is in your population for potential treatment planning. The Ki67 assay, which is a proliferation marker, is really a surrogate for the tumor grade, how aggressive it is. And so that can support the pathologist's assigned grade. And then the mRNA assay could be deployed to hospitals that have tissue processing capacity and not just the select few that have the ability to perform immunohistochemistry. So in summary, I've told you about some leapfrog technologies that can improve breast cancer diagnosis. We've got telepathology that can provide and improve the quality of pathology diagnoses, computer-assisted diagnosis, which could be used to guide tissue allocation by technologists. It can provide preliminary cancer diagnosis or even biomarker assessments. And then we have molecular evaluation of prognostic markers that will hopefully reduce costs and solve many of the quality control issues. Thank you very much.
Thank you very much, Jane, for a very interesting lecture. I have a couple of questions for you too. The first one would be, you have exposure to working in low to middle income countries. What would you consider the most cost-effective and time-saving way to get breast cancer tissue from our patients?
That's a tough one because the cheapest and quickest is a fine needle aspirate, but it's not the best way of doing it because the fine needle aspirate pathology has its limitations and it's actually really hard to do as a pathologist. Core needle biopsy is really the optimum, and we just have to solve the problem of how to get the cheaper coaxial needles and use disposable biopsy devices. When it comes to biomarker analysis, I'm really hopeful that using an mRNA assay will be both cheaper and better than immunohistochemistry. I really hope that pans out.
What would you say about a wedge biopsy? Because people like to do that.
The wedge biopsy, so you know, there are problems with that. First of all, you need a surgeon, right, who can take the biopsy. So it's a little bit more of a major procedure than a core needle biopsy. You need to use anesthesia, you need sutures. You've got all of the sort of hidden costs in that, which you're not really thinking about, you know, compared to, say, the cost of a needle for the disposable core needle biopsy. You know, if that's all you've got, it's good. The other disadvantage of the wedge biopsy is that it's a skin biopsy. And so if your tumor is not close to the skin, you know, you might not actually be able to get a sample of the tumor in that wedge biopsy.
Okay. My second question, do you think it's about time to start decentralizing pathology services in low to middle income countries where we don't have that many pathologists? I'm not sure we'll ever solve that problem. Do you think we're getting there?
So decentralizing, some things can be decentralized and some things need to remain centralized. If you have limited pathologists in your country or no pathologists in your country, then obviously your solution is to use leapfrog technology to get a telepathology service in play so that you can, farm out your pathology diagnoses to where you can get access to that that pathologist support.
Thank you. The last but not the least question. We have all these giant technological companies helping with breast cancer diagnosis. Are they stakeholders in this teamwork that we are asserting to?
My opinion is that they are definitely committed to solving the problems and that they definitely have their hearts and minds in the right place. That's all I can basically say.
Okay. Thank you very much, Jane. Thank you very much. I would like to move on to the third speaker, which is Frances Fitzgerald. She's an Irish Member of Parliament from the Dublin, elected to the European Parliament in 2019. She's been a parliamentarian for over 20 years, served as a Deputy Minister and Substantive Minister in various portfolios prior to her current position. She previously served on the board of the Breast Cancer Research Foundation of St. Vincent's Hospital in Dublin, and the vice chair of Europa Donor, the European Breast Cancer Coalition. She's the current chair of Transforming Breast Cancer Together, a policy and advocacy think tank to shape the landscape of breast cancer in Europe through multi-stakeholder engagements. The title of her talk will be Multi-Sectoral Collaboration and Policy Advocacy, Defining Breast Cancer Priorities at a Regional Level and Transforming Breast Cancer Together.
Dear World Cancer Leader Summit participants, esteemed fellow speakers, ladies and gentlemen, I'm delighted to be here to present to you on this very important topic of multi-sectoral collaboration and policy advocacy within the Breast Cancer On Air session. I'd also like to congratulate you in what is shaping up to be a great event on the very important topic of breast cancer. I am delighted to present at the Union for International Cancer Control event, and I would like to thank you for the invitation and an opportunity to present the work I'm involved in our multi-stakeholder initiative, Transforming Breast Cancer Together. It is what it says. It's about all of us working together. And particularly from my own experience as a politician who's always been interested in breast cancer and worked with advocacy groups and then worked in multi-stakeholder groups and various foundations, Europa Donor and the Marie Keating Foundation in Ireland, I have increasingly come to believe that it's actually about all of us working together in the way that we do in TBCI. I think it's really important to bring together different experts. And it doesn't happen as much as you would expect it to. So I think that we get the best results when we present medical insights and we work with our physicians with their extraordinary expertise, always developing and undisputed innovation and expertise. And they want to bring that innovation to patients. And that's a whole topic in itself. How do we bring these new innovations in medicines and devices direct to our patients? Secondly, the patient's perspective. We have to listen to our patients. We have to listen to the advocates. We have to hear what they have to say. And that means you look at new areas like, pathways back to employment, for example, the right to be forgotten, and so on. Very often these ideas come from the patient advocacy organizations. We can learn a lot from listening to them. Then, of course, there's the industry's know-how, its commitment towards improved quality of care for patients' well-being and drive for innovation. These are points we cannot do without, and many topics arise when we look at it from an industry perspective. Primarily, again, I would say about innovation, about access, collaboration, all incredibly important. And then, of course, the policymakers, the group to which I belong. We have to bring insights to policy decisions. We have to provide gateways into policy making. I would say we have to build more bridges between the policymakers, the physicians, the patients, and the industry. Bridge building is really important because you've got to get your policymakers informed, interested, motivated, to make sure that breast cancer continues to be a priority. So the essence of TBCI is about those various groups working together in collaboration on a range of different approaches. And so what we want to do always is we want to elevate the impact of good policies on breast cancer. We want to reduce the impact of breast cancer by elevating it as a health policy priority to improve breast cancer prevention, diagnosis, and care across Europe. And in each of those areas, there's work to be done, as everybody attending this conference knows. Cancer prevention, much work to be done there, including, for example, looking at the impact of COVID-19 on screening and perhaps dealing with people's fears when they have symptoms, making sure they still go to their GP. And we know cancer services declined during the period of COVID, and we now have to make sure that we accelerate availability of screening and access to specialists, and that even though COVID continues in various forms, that it does not over impact on the access to the kind of services that breast cancer patients need. So what else do we have to do? We have to do advocacy and raising awareness. We have to do engagement with EU policymakers and patient empowerment, to sum up the three different areas that we are involved in. Now, you have to say that sometimes people think breast cancer gets too much attention compared to other cancers. Well, does it? No, of course it doesn't, because the World Health Organization recently announced that breast cancer is the most common cancer worldwide, surpassing even lung cancer. Over 55,000 women in the EU 27 are estimated to be diagnosed with breast cancer annually. This represents 13.3% of all cancer diagnoses. So this tells us a whole lot needs to be done to ensure that throughout the whole disease pathway, we have better prevention, early screening, timely diagnosis, and treatment at different stages of breast cancer. The whole journey, we need to work on all of those different areas and those timelines. Now, we recently, looking at impacting on policymakers, we recently did a renewed call for change, which highlighted the challenges and the lessons learned from COVID-19 and the importance of the implementation of that great plan, which is Europe's Beating Cancer Plan. We also, of course, have the very important report. It's a draft report at this stage, the Special Committee's report on beating cancer, strengthening Europe in the fight against cancer towards a comprehensive and coordinated strategy. We're supporting that. We're working with everyone who's involved in it. So I think the really good news from I can give you as a parliamentarian in Europe is there is a huge interest in health issues. There's a huge interest in working on cancer awareness, prevention, and better treatments, probably now more than ever. So this is a good time for all of us to engage together at all of those different levels that I spoke about, because I do think it's very high on the European agenda, this huge European commitment to achieving a 90% target for breast cancer screening of the EU population who qualify for screening by 2025. Now, we know that there's unequal access across Europe at present, and it's very disturbing to see the statistics on that. We see Western Europe doing better than Eastern Europe. We see women getting very different levels of care. We don't see enough specialist centres. We see screening not necessarily being available to everyone who needs it. So much work to be done in terms of equity. The equity principle is really important that we begin to handle that. So on patient empowerment, there's a lot we can do. It's about reaching out to every woman who has been diagnosed. It's about talking to young women and girls. It's about talking to older women. It's about making sure that when screening ends in a public health service, that women continue to get screening, that we make it accessible and affordable in the earlier years and the later years when screening, as I say, may not be available. So patient empowerment is very, very important. And we need to do more and more national and international events on patient empowerment. So I would say that our organisation is more than the sum of the different parts. It's about really including different perspectives. So you don't work in traditional silos. Traditional silos don't work anymore because we can't stay in the same circle of influence and information and expertise. We have to reach out, especially at a time of so much innovation in medicine, in science, in research. And takes a village to raise a child. And taking this image to the area of cancer care, it also needs a unified voice and collaboration between different stakeholders to reach our goal of better breast cancer care for all. I know that people believe this, but sometimes actually getting the places where we engage together can be difficult for very busy professionals, but we've got to do it. We've got to find those forums, those collaborative opportunities where we can bring those different stakeholders together in order to plan better cancer care. I believe it's happening more and more. Let's ensure it's consistent and comprehensive across Europe, and we all gain from one another and improve the cancer care services available for those who are diagnosed with breast cancer across Europe.
You recently published an article on the renewed call for change, galvanized by the pandemic. Could you explain how the pandemic led to the renewed call for change in implementing European Cancer Plan?
Well, the first call for change was a couple of years ago, and that was the core advocacy document for the Transforming Breast Cancer Together initiative. That was about increasing the understanding of living, the daily realities of living with breast cancer in Europe, and ensuring that policy making reflected both the individual and societal burden that was involved. And it was aimed at the EU institutions, EU member states. However, the pandemic has brought additional challenges. We all know that, particularly to breast cancer, where screening programs play an important role in achieving timely diagnosis. Many hospitals diverted their efforts during COVID away from cancer clinics, or they suspended screening or limited their service. And of course, we were worried about this, and we said so at the beginning. Now, over a year on, we published a renewed call for change a year after the pandemic. This is where we say that the crisis brings an opportunity for us to be better prepared to deliver breast care for all our patients in the EU. I suppose what the pandemic has taught us is that we have to be open to a variety of ideas and processes that previously were thought to be unacceptable, such as telemedicine and e-consultations with physicians. Listening to our physicians speak about the changes, the access to patients, the use of new technology. Obviously, we still need face-to-face engagement, but there is an awful lot we can learn from what we've had to do so unexpectedly and so quickly during the pandemic to make services available more quickly to patients, and perhaps, definitely use data to better inform our patients and ensure safety and continuity of care. So if we can use digital and data and strengthen our healthcare systems, as we've had to do during COVID, and so we're pointing out in our new call for change that we welcome the European Commission's Europe Beating Cancer Plan, and we urge EU policymakers to learn the lessons from the pandemic and give the necessary attention to breast cancer care when implementing that plan, because as we know, it still affects so many patients throughout Europe.
So thank you everyone and our speakers for this wonderful session together. These talks have been very enlightening, and we are glad to see partnership with WHO, the UICC, and insights from the European Parliament aim to improve breast cancer outcomes globally. A unified and stratified approach to address bottlenecks in tackling the most common cancer worldwide. It's far overdue. The lessons learned from high-income countries are not usually adaptable in low to middle income countries, but a stepping stone to innovation and sustainability of services required to ensure equity in breast cancer outcomes globally. Obviously, we need a multi-pronged approach, needless to say, best served with the patient-centered multi-stakeholder engagement driven by policy. Thank you very much and have a good day. Thank you.